Hello, it's a pleasure to talk in this online program about renal denervation. My name is Andrew Sharp. I'm a consultant cardiologist from the University Hospital of Wales in Cardiff in the United Kingdom. I'm going to focus today on advances in the renal denervation procedure that have taken place over the last 5 or 6 years, specifically focusing on radiofrequency ablation as the tool of delivering renal denervation. These are my conflicts of interest. So renal denervation with radiofrequency energy has been extensively tested and developed over the last 8 or 9 years. We started with a single point catheter, the original Simplicity Flex, and have now moved on to a Simplicity Spyral device that's designed to simultaneously deliver radiofrequency energy into the wall of the renal arteries, specifically into the periadventitial fat, so the fat that supports the renal artery within the abdomen. This fat contains the renal sympathetic nerves. So the renal sympathetic nerves are the fight or flight nerves that form about 30% of the sympathetic nervous system, and they are one of several systems that are involved in the maintenance of blood pressure and the maintenance of salt and water handling within the kidney. They therefore play an important role in the development and maintenance of high blood pressure. So the purpose of denervation is to deliver a catheter percutaneously under local anesthetic into the top of the leg, into the femoral artery, as we would do if we were going to do a coronary angiogram, for example. We then pass it up to the kidneys through the aorta under fluoroscopy guidance. We place the catheter inside the renal artery and we deliver radiofrequency energy into the wall of the renal artery to heat up the tissue around the artery, typically to between 55 and 80 degrees, depending on the distance from the artery. So we're ablating the renal afferent nerves and we're ablating the renal efferent nerves with the aim of permanently disconnecting them, destroying them. So the purpose of renal denervation is to deliver energy into the periadventitial fat that surrounds the renal arteries with the aim of denervating the renal nerves that travel between the brain and the kidney and back again. Here you see a pathology slide taken from, in this case, a pig model, where we see the renal artery there highlighted in the middle right of the picture. And this is a pathology slide of a section that has received denervation and has subsequently been analyzed. And you'll see how relatively disparate the transition of energy is through the surrounding tissues. And that's because when radiofrequency energy is delivered through the wall of the artery and the heat is delivered into the surrounding structures, it will conduct according to the conductance of all of the substances that surround it. So here you see highlighted in red some of the renal sympathetic nerves and how the fat has been necrosed and is beginning to fibrose in that area, and how it forms not a uniform circle around the renal artery, but actually a relatively changing structure according to the relative conductance of the tissues. We've analyzed about 400 pigs and about 10 human cadavers in order to understand how energy travels within the periadventitial space and affects renal sympathetic nerves. So we've got a pretty good understanding now of how this works and what energies are required and how far they travel within the average model. So in summary, when we look at this slide, what we're looking at is the renal sympathetic nerves lying fat sitting around the renal artery. And as we deliver a denervation using radiofrequency, we deliver that denervation into the fat tissues around the artery, denervating the renal sympathetic nerves safely and effectively. So here you see on the left what happens when you deliver energy from an ablation catheter into a gel model. So this is the Spyral catheter, which is a 4-point catheter that forms a retrograde spiral on a nitinol delivery catheter. So what you do is you wire into the renal artery, you slide the Spyral catheter over the wire, you pull the wire back, and then the Spyral catheter will spring into the shape of the artery with ablation catheters north, south, east, and but it will do so in a retrograde staggered fashion, so we don't get all 4 points being ablated at the same position within the renal artery. And when you deliver that into a gel model, you get beautiful symmetrical images like this because you have uniform conductance within the gel model. And so one might think that this is how renal denervation with radiofrequency is going to perform in an animal model. But animals just aren't the same as thermochromic gel. So you see more on the right, a 7-day porcine model, how a single ablation lesion coming from a single RF electrode is producing more of a crescent than a circle, and how it's covering about 90 degrees of the arc around the renal artery, but not necessarily in a uniform fashion. So here we've managed to get some of the renal sympathetic nerves, but that's quite an easy ablation for the technology to deliver because there aren't any structures abutting the renal artery in this crescent, and therefore we're able to get a good single ablation there. So in summary, you can see in a thermochromic gel model on the left, if you deliver 4 denervations, you get circumferential denervation. On the right, we see a single point denervation creating a 90-degree crescent of effective denervation, albeit a slightly more complex shape. But you can imagine how if we use the 4 poles of the Spyral catheter to deliver north, south, east, and west, how we are going to recreate a circumferential ablation in a staggered fashion along the renal artery in a safe fashion. And when we look across hundreds of animal model samples, we can work out 2 measures of depth of ablation. So depth of ablation is talked a lot about in this field, and we sometimes get quite simplistic numbers given. So sometimes people will talk about 4 or 6 or 8, but actually there's a little bit more to it than that. And that's only one number in terms of a diameter of either a hemisphere or even a quadrant of a sphere. So when we looked at all of these animal models, we saw that there was an average depth of ablation of about 4 millimeters from a single ablation, but that at various points within the arc created by that single denervation, sometimes the depth will go out to about 7 millimeters. So you've seen already how relatively complex a denervation arc is within the periadventitial fat where the renal sympathetic nerves stay. So I think I've previously myself given talks where I've talked about 4 millimeters or 6 millimeters, but it's a little bit more complex than that. One needs to start thinking about ablations created with this technology in terms of a cloud of energy that distributes out from the renal artery into the fat, and it will its depth will depend upon the structures it comes into contact with and the conductance of those tissues. So here we have a much more complex lesion. So in the center of the image, we see the renal artery. Of course, in a sacrifice model pathology specimen, we see collapse of a lot of tubular structures, but this would be a circular structure if this was a live model. And then you see a shape that actually looks a little bit like the map of Great Britain across slightly to the right of it. And you see how when you look slightly below the artery, you have maybe a 1, 2, 3 millimeter depth. And then you look towards 3 o'clock to the right of the renal artery, and maybe we get out to 4 or 5 millimeters. But you see how the energy is actually ran towards 12 o'clock in the image, out to 8, 9 millimeters of depth. And that's because the energy will just flow until it's dissipated by the conductance of the tissues around it. You can see there's various structures around. You have a lymph node to the left. You have another vessel structure to the right, and then you have muscle at the back. And so these will absorb the radiofrequency energy emitted from within the renal artery with different properties. And some of them just won't conduct at all. And therefore, you're going to get this somewhat fluent structure, much like if a dam was broken and water would flow down the path of least resistance. Well, here you have energy flowing through the periadventitial fat. And we need to be thinking of each ablation as more like a cloud, a 3-dimensional model, delivering energy in all directions according to the conductance of the tissues around it. If it hits a structure such as a lymph node or the renal vein, then the energy is dissipated. But it's dissipated by flow within these structures, which carry away the energy, and therefore there's no harm to any of these tissues when we look at them in prosections afterwards in hundreds of animal models. So with our understanding of both the way ablation works with radiofrequency and of anatomy, the procedural technique for radiofrequency renal denervation has changed. So we understand a few key anatomical messages that we didn't fully appreciate 5 to 10 years ago when this field was in its nascency. So firstly, and most importantly, the renal sympathetic nerves come down from the brain close to the aorta, and then as the renal arteries come off the aorta, the renal sympathetic nerves will come off the wall of the aorta towards the kidney, and they will start quite far away in terms of the proximal renal artery, and then they will get close to the renal artery as it gets nearer the kidneys. In other words, the more distal you go within the renal artery, the closer the renal sympathetic nerves are. Now, this is a different understanding to how we started this field. When we started this field, we thought that there was relative uniformity of the distance of the renal sympathetic nerves from the renal artery. So when we were doing the original techniques, it felt sensible to deliver and focus most of your energy on the proximal end of the renal artery and to stay away from the distal end of the renal artery where the kidney material was. In fact, that's the exact opposite of what we should be doing with radiofrequency ablation. So we need to be delivering energy closer to the kidney, but clearly not within the kidney parenchyma. We want to be outside of that, within the renal artery. And that way, we are able to deliver energy into nerves that are likely to be wrapped around the vessel at that point, as opposed to far away from the vessel, which might be the case in the proximal vessel. The second understanding, which we've always had, but we've got much better science now in terms of understanding just how much ablation we need to deliver and whether it needs to be circumferential in order to achieve a blood pressure response. So perhaps this isn't surprising to any of you. We need to get circumferential ablation in order to get a good response. So in other words, we need to denervate north, south, east, and west to make sure we get the whole vessel around it. And if we do so, we got a higher likelihood of a blood pressure response. So with the original single point catheter that was used, the Simplicity Flex, in the early research, that was an operator dependent phenomenon. But now you can see a picture in the top right corner there of the Spyral catheter, which automatically forms a circle, a spiral, and will do most of the work for you in delivering energy in a circumferential manner to north, south, east, and west within the vessel. We've also now got thousands of patients in registries and studies showing that radiofrequency ablation is very safe. In fact, vascular access is more dangerous than doing a renal denervation procedure. And even then, we're pretty good at it now with ultrasound-guided micropuncture techniques. So we've even made that a very safe procedure to perform. This is the image that really illustrates the points I was referring to earlier. So here you have a prosection of a human kidney, and then you have the aorta to the right of the image that you see, the left hand of the two. And then you have what look like small round structures near the aorta. They're the renal ganglia, that are the junction boxes between the central nervous system and the sympathetic nerves as they travel to the kidneys. You then have nerves coming from those ganglia, and they wrap around the renal artery at around about the bifurcation. So you can see how proximally in the renal artery they can be far away. That will be 12, 13 millimeters right at the origin of the renal artery. But then as they come down distally and wrap around the branches, then you'll see that they're right on top of the vessel. They're within 1, 2, 3 millimeters. So you can see how intuitively that we got the technique wrong at the beginning when we first started 10 years ago by focusing proximally. What we should have been doing was delivering radiofrequency distally, and then we can more easily come into contact with the renal sympathetic nerves at the controlled, safe levels of energy that we like to give with the radiofrequency catheter. The image on the right is the back of the same kidney, so you can see it, the front and the back on the left and the right. And again, you get this impression that you may not be able to deliver energy to the proximal section, but you can easily target the nerves as they wrap around the bifurcation. So here we see what's the so-called IV model, IVY. So this is an animal experiment that was led by Felix Mahfoud. And what they did was they looked in a porcine model in pigs at what happens if you deliver renal denervation energy to the distal main artery only. And you can see we get about a 70% reduction in renal norepinephrine levels. So that's pretty good. But if you deliver into the branches alone, then you get about an 83% reduction in renal norepinephrine levels. So you can see how we're getting more effective signals of denervation the more distally we go within the arterial system. And then when you put them both together, to create a Y. So you have an I for the main, a V for the branches. You put them both together, you get a Y, so-called Ivy technique. Then you get a 92% reduction in renal norepinephrine. And we think that the greater reduction in norepinephrine that we see, the more likely we are to have successfully denervated and therefore get a blood pressure response. This has now been tested in sham control trials successfully. We've published several in the Lancet in the last few years. You see that on 24-hour ambulatory BP, which really is the gold standard now for measurement of blood pressure response, we're seeing in the off-med pivotal, where we took patients off medicines, we denervated them, and then at 3 months looked at the difference between a sham control and a denervation procedure. There was a blood pressure drop of 4.7 in the denervated arm and 0.6 in the sham arm. So a difference of about 4 millimeters of mercury on ambulatory blood pressure recording. The on-med pilot study, which was 40 patients denervated and 40 patients sham. Again, a much bigger fall in blood pressure, about 9 millimeters of mercury, raising the possibility of a synergism between drugs and denervation. But I think it was important we had the off-med study as well, just to get drugs out of the way and show a clean signal of the effectiveness of denervation in reducing blood pressure. And off-med pivotals, 300 patients, so it's a large sham study that very few other device technologies have. When you look at office blood pressure, that's what you and I will measure when we're in a clinic. Again, we're looking at 9 points roughly of drop, which will be expected to reduce the risk of stroke by about a quarter, heart failure by a quarter, and major cardiovascular events by about a fifth. So well worth having. Here you see the Medtronic program. To date, we've had hypertension 1, 2, and 3, which was with the original Simplicity Flex. And then following the reboot with the Spyral catheter, we have 2 pilot studies of off-med and on-med, followed by the major pivotal trial that was published in the Lancet recently. On-med trial at a scale of over 250 patients is ongoing and will hopefully report next year. And there is a patient preference study that's being organized just to see whether patients would want this procedure as part of their hypertension package. I'm now just going to talk about the next phase of renal denervation research, which is the Spyral distal study. So the purpose of the Spyral distal study is to establish whether we can streamline the procedure, make it more efficient, and achieve the same or similar blood pressure reductions. So what we're going to do is focus on the distal branches, which we've described earlier on in this presentation as being the key to delivering radiofrequency energy to the renal sympathetic nerves. So instead of just denervating every section of the artery that we could, which is what we did in the recent off-med and on-med studies, we're going to focus on the distal main renal artery, the first order branches, and any accessory vessels. And we think by doing this more focused approach, we can reduce the number of ablations by about 40%. So it'll be a design similar to the off-med study, where we do our first visit, take them off drugs, and then we're looking for mild to moderate hypertension off drugs, so 150 to 180 systolic and above 90 diastolic. They'll then be screened with ambulatory blood pressure monitoring again to confirm moderate hypertension, 140 to 170. They'll then have a single arm study, this one, there's no sham control. We're just going to denervate a cohort of patients and then compare them to the off-med study. And that's why we've designed this group to be very similar in the selection criteria to the off-med study. And then we see whether or not we get similar magnitudes of reduction. And then we can start to think about whether this is a procedure that can be streamlined in order to make the cath lab experience a better one for patients. I've mentioned mild to moderate hypertension, and we're looking for patients with relatively preserved renal function and absence of uncontrolled diabetes or type 1 diabetes. So what are the purposes of Spyral distal? It's to try and target treatment strategy, but preserve effectiveness, to decrease exposure to radiation, periprocedural drugs like sedation, analgesia, reduce time in the cath lab, which is better for everybody, and to reduce contrast use, which is certainly better for the patient, as is reducing the number of denervations, which do stimulate a pain response requiring some sedation and analgesia, which is manageable, but we're better off having less of that with any procedure. So Spyral distal will start soon. It would have started already, but for the recent issues with COVID, and we're looking forward to recruiting to that quickly and delivering the information back to the field and seeing how the field evolves over the coming years. Thanks very much.